Okay, good morning, America, and a very good evening, India. So, it is a real honor to me to host this event that is COVID-19 Therapeutics, where we are now. And for that, I just want to thank American Academy of Yoga and Meditation to give me this wonderful opportunity. And I also thank Ganges Mississippi Dialogue, that society, which give me this wonderful opportunity. And I am also thankful to Dr. Indranil Bosuray, especially for providing me this e-stage. And to discuss about COVID-19 therapeutics, which is often talked nowadays. And if we just go back to 8 months back, the Indian situation, we don't have any knowledge about this disease. And as the COVID-19 pandemic has caught the whole world unawares and clueless, with no specific therapy and vaccine to contain this menace, it is a really challenging situation that time. But at the present moment, we get many drugs that shows some benefits, and we are using it to our patients, and we are getting some benefits. We know that COVID-19, that generally causing fever, severe respiratory illness, and pneumonia, first appeared in December 2019 in China, and that causes severe acute respiratory syndrome, or SARS-CoV-2. We generally denote as severe acute respiratory syndrome. And this is caused by one typical virus, SARS-CoV-2 virus. And till date, it infected more than 19 million, 20 million people in a span of less than 8 months. And with a death toll of more than 700,000. And we are very soon going to reach that 1,000 toll. And if we consider the morbidity and human fatalities, it is 10 times as compared to the seasonal flu. And we should have some strategies to contain the pandemic, and that necessitates different interventions and different measures. Specifically, we all want vaccine now. But apart from that, today's topic generally on the therapeutics portion, and therapeutics for COVID-19 is based on one principle, that is drug repurposing. What is that? Drug repurposing or repositioning? It is one type of technique whereby the existing drugs are used to treat the emerging and challenging diseases. In this case, it is COVID-19. And drug repurposing has become a promising approach because the opportunity for reduced development timelines and overall cost, because we have a very small time. We have a small time, but we need to save a huge number of people. So this compressed timeline demands very high effective drug development strategies. And for that, drug repurposing has no alternative. And for that, we just mention a beautiful quote by a Nobel Prize winning pharmacologist, Sir James Black. He had said that the most fruitful basis for the discovery of a new drug is to start with an old drug. So that is the basis for drug repurposing. So now it is my honor to introduce today's speaker, Professor Shantanu Kumar Tripathi, who had done his MD and DM in clinical pharmacology long back, and he is one of the famous person in the field of clinical pharmacology and therapeutics in India. He is now professor and head of Department of Clinical Pharmacology in School of Tropical Medicine, and he is also associated with multiple drug regulatory bodies in India and different ethics committees. So it is my pleasure to introduce my professor Shantanu Kumar Tripathi in front of all audiences. Sir, now the E stage is yours.
Thank you very much, Dr. Shambo, for your kind words of introduction. And I must, before I start, uh, I'll be failing in my duty if I do not really acknowledge and extend my gratitude to IAM and Dr. Indranil Basure in particular, that I have been given this opportunity and offered this platform to deliberate on an issue which is otherwise very much uh, hot topic, you can say, in this pandemic. We have been through this pandemic almost since February in this country, and in some other parts of the world it is actually from the later part of the last year. Okay, as we know, it is almost 10 months that the global community and the people from different parts of the world, they are actually facing this uh, disaster, we can say. And in whatever capacity we can fight this pandemic, we are trying to. This is absolutely a new disease. Okay, we had no clue whatsoever how to fight this disease, how to prevent this disease, how to treat this disease. It has been thrust upon us. And so, as Dr. Shambo was mentioning, that when this kind of a situation comes, absolutely a new, uh, unprecedented disease comes, and in that scale, okay, with a very high transmissibility, okay, very rapid spread of the infection. So, there is no vaccine. There was also in the initial stage, there were also dilemma in how to diagnose the disease even. Okay, so we are learning in a very hard way. We are learning how to diagnose, we are learning how to treat, we are also learning how to prevent. Okay, so definitely we are a little better off than we had been in the early part of this year. But then we cannot say we have understood this disease thoroughly. Okay, uh, it will take further time. So this is the uh, this is the overall situation. We are in a learning phase still, and we really do not know. It's still uncertain how long this pandemic will continue to bother us, trouble us. uh, we are yet to have a vaccine. The concept of herd immunity is something which probably is not going to help much, because in order to have the benefit of herd immunity, you need to have two-thirds of the population needs to be otherwise developed the protection or the immunity by sufficient antibody titer. But then the time that will take for the herd immunity to reach may prove very dear, because during that period, although the disease as such is not truly speaking to that extent fatal, the fatality rate is not that great as compared to many other infectious disease. But then, because of the high transmissibility, even if there is 1% fatality, the absolute number of fatality will be very huge. So that's the reason we possibly cannot wait for the natural immunity to occur, okay, through transmission of infection, and we need to induce the immunity by using vaccine. But until the vaccine comes, we need to treat. Okay, we need to, you can say, buy time. And then uh, when you say we need to treat, we need to have the proper drug to treat. uh, a drug, one can think of developing a drug when we have understood a disease. Here is a disease, we didn't understand the disease at the very first place, and developing a new drug again has its own incubation period. You cannot think of getting a drug, specific drug, overnight. And that's the reason when it came thrust upon us, then we wanted to actually fight with whatever weapon we have. And so we looked at the backyard and see whatever existing drugs are there. If there is a theoretical rationale that this can be effective, this can actually act. Okay, we have tried all sorts of such possible measures or possible pharmacological solutions, what Dr. Shambhu was actually referring to as repurposed drug or repositioned drugs. Basically, it should be taken as off-label medicines. They are all old, trusted, time-tested medicines. But then, to what extent they will actually, these old drugs, okay, will actually be effective in this new disease, that was anybody's guess. Uh, in order to prove that these drugs otherwise will also be effective in COVID-19, one again needs to design proper trials, proper clinical trials. Okay, so that itself again, for planning a trial, for implementing a trial, and completing a trial, uh, coming out with a conclusion. Okay, that again, it takes time. So we are actually, you can say, using the different drugs on an experimental mode, and through this experimentation we are also learning, so that subsequent patients or future patients, they are getting some benefit of this experimentation. Okay, uh, and that's how we are learning. With these few words, let us now uh, discuss some of the slides, okay, in so that we can, in an organized manner, we can present whatever we have learned up till now about management of this disease. Can I have the slides, please? Yeah. So can it be a little larger than this full screen, or maybe there is some technical issues? Okay, let me go with this. So we'll be discussing this COVID-19 therapeutics, where we stand today. Next, please. Can I go to the next slide? Yeah, this is what we are going to discuss. We will try to know the disease, whatever we know up till now. We'll try to then try to understand what different drugs can be used to treat this disease, and then what are the different current evidences in favor of these different weapons or different drugs that we are using for treating this disease. This is broadly how we have planned our discussion today. Next, please. Go to the next slide, please. Yeah. So this is what is the how the virus, the enemy, it looks like. So it's named as SARS-CoV-2 virus. Okay. So severe acute respiratory syndrome, COVID, uh, or the infectious disease, viral infectious disease. COVID is actually uh, the coronavirus infectious disease, COVID uh, 2, because there was one coronavirus attack in the early part of the century, that is in 2003 or 4, around that time. So of course that time it was not named as COV1, because we never knew there will be a second coronavirus will come and attack us. So it was coronavirus. And then when this in 2019 end in Wuhan in China, this new coronavirus came, which started causing havoc. So it was named then as SARS-CoV-2 virus, and this is how it looks like. It is an RNA virus, and there are these spike proteins. Okay, the spike proteins are actually the you can say the characteristic feature of this virus. And actually through this protein, spike protein, it tries to enter into the cell. Okay, and the virus actually prefers the respiratory epithelium or the lung cell, and that's why it is called also a respiratory virus. Although there are also instances that not just respiratory epithelium, it can, though rarely, the other the GI epithelium can also be attacked by this virus, but mostly it is the respiratory epithelium. Okay, that is the preferred preferred site where the virus likes to enter and reside, and then tries to enter into the cell through a receptor, that is this angiotensin converting enzyme 2 receptor. So this receptor and the spike protein of the virus, they will interact, and that will actually lead to uh, entry of the virus into the cell, and that's how the virus actually infects a cell, and then uses the inner cellular material in order to actually multiply. Okay, and after it multiplies, it comes out of the cell. So that's how it goes. Can I have the next slide, please? Next slide. Yeah. So when you try to fight this disease, okay, at the initial phase we had nothing to fight with, but then whatever little we could understand the disease, we understood that it is a contagious disease. It's a viral disorder. So viral disorder will transmit. Okay, uh, there are different ways of transmission, but so far as this viral disease is concerned, people, we understood very soon that it is transmitted through uh, close contact, but then through the aerosols, okay, or rather through droplets. It is transmitted through droplets when we cough, or when we speak loudly, okay, or when we sing, when we sneeze. So the viral particle from my respiratory epithelium, or from my nostril, from my upper oropharynx, so they will come out, and the the droplets will have different sizes. The coarse droplets, which will, because they are heavy, they will immediately precipitate, drop down in the floor. The finer droplets will remain in the air for relatively longer time, and will possibly travel to a longer distance, and then they may precipitate on the floor or any other surface. So when we understood this, we said that if you exercise cough etiquette, okay, you close your mouth, or you use a mask, okay, barrier, okay, on your nose and your mouth, to a great extent you are actually preventing transmission of the infection. The other thing is about social distancing, or rather uh, maintaining a physical distance between two persons, because the droplet cannot travel, okay, say more than say 2 feet or 3 feet. So it is strategically better to maintain a distance of 2 or 3 feet, so that you can, even if somebody is coughing, so that droplet will not reach you, if you are maintaining a distance of 3 feet. So that's how social distancing, or rather more correctly maybe physical distancing, that helps. Use of mask helps. Cough etiquette means you cover your mouth when you are coughing, and of course, if the surfaces are contaminated with the virus in the form of the droplet, and then if I touch a surface, and then if I touch my mouth or my nose or my ear, there is likelihood that uh, I'm actually encouraging, or I'm actually facilitating the transmission of the disease. Okay, the virus now comes to my mouth or comes to my nose, and thereby it will infect me. So that's why it is said that sanitization, hand sanitization or hand wash. Okay, there are huge number of different hand sanitizers that have flooded the market, and so each time when you are uh, touching a surface, unknown surface, so it is better to wash your hand with soap water. Okay, this is a virus. Thankfully, it cannot survive. Okay, detergents or any other antiseptic. Okay, antiseptics or disinfectants, they will kill the virus. So hand wash or hand sanitization, mask, cough etiquette, social distancing, these are what is called behavioral countermeasures. Okay, behavioral countermeasures or public health behavioral countermeasures. But then, in order to consider medical countermeasures, we had to wait for some time, and then we understood that what kind of medical countermeasures might help, and we tried to find solution in the existing medicines, okay, pharmaceuticals that are already there for treating other diseases. Okay, and then we found it is possible, and some of the early researches for treating similar kind of viral diseases, and then we found we have some indication that some of the existing old molecules, they could help either in prevention or in treatment or in both. And uh, some such old molecules have been tried with some and varying degrees of evidences that have been also generated. But people, when nothing was there, people started using them, like hydroxychloroquine, like ivermectin, like doxycycline, like the uh, other azithromycin, etc., etc. So and then some people, they also, some scientists also tried to do generate some evidence that they are working. Of course, generating evidence has its own challenge also. COVID research itself has its own limitation and challenges because of obvious reason of this transmissibility. And so maintain need for maintaining distance, hand washing, etc. So there are also natural kind of barriers or natural kind of challenges of doing COVID research. Okay, following the usual guidelines that are there for conduct of research, good clinical practice guidelines, etc. But even then, because of the extreme need, people laid their hands in these kind of research, okay, with a particular focus to come out with newer uh, pharmacological solutions to this particular disease. And broadly speaking, if you think of as on today, what are the different kinds of pharmacological solutions that we have today? Okay, we'll just discuss some of them. Okay, time might not permit to go into great depth or details of each and everything about all these different medicines that have been tried or that are being tried in the treatment of COVID. Okay, but we'll try to just touch upon some of the more critical information. So far as prevention is concerned, yes, we have to think of immunoprophylaxis with use of specific vaccines. But then again, people have tried to also use non-specific vaccines, trying to see whether the non-specific vaccines like BCG, like measles, like MIP vaccine, which is anti-leprosy vaccine, okay, like oral polio vaccine, whether they can confer some degree of non-specific immunity, and as a result of which whether people can prevent, okay, transmission of or the manifestation of the disease of COVID. So this is also being tried. There are a good number of trials that are going on with all these different types of non-specific protection, potential non-specific protection by the different other vaccines. So you can say this is also repositioning of vaccines. Okay, borrowing the language from Dr. Shambo. Chemoprophylaxis means when you are trying to prevent a disease by using chemical substance instead of immunological candidates. So that means by drug, by using small molecule drugs. That is what is called chemoprophylaxis. We have chemoprophylaxis of, say, malaria, chemoprophylaxis of tuberculosis with isoniazid, chemoprophylaxis of malaria with, say, chloroquine, etc. So one can think of using chemoprophylaxis, and here people have tried hydroxychloroquine. Of course, there were some indication that it can help. There were some data available, although it is in vitro studies, but some data available that hydroxychloroquine might help. It might have some antiviral effect, okay, and it might also have some, additionally, some other kind of mechanism might be involved by which it could help, and people started using it. And at least in India, uh, uh, ICMR came up with some empiric guidelines for use of hydroxychloroquine in healthcare workers. Okay, uh, and that is still continuing. That has not been revoked. Although there are different uh, counter evidences from different parts of the world, but then again, uh, they are not enough convincing. Okay, so in India, at least ICMR has retained its advice of use of hydroxychloroquine for prevention of uh, COVID-19, particularly in healthcare workers and also high risk patients who are at relatively higher risk of contracting the disease or at a higher risk of having severe disease, like people with diabetes or people with cardiac disease, okay, hypertension, heart failure, etc., people with chronic kidney disease, etc. So they are considered to be at higher risk, and it is expected that they would benefit from the chemoprophylactic regime with hydroxychloroquine. although it also has some concern that it can cause uh, the QT prolongation and thereby some degree of rhythm disturbance. And but then that is understood to be quite rare, and only those who are more vulnerable, who have a past history of heart disease, particularly with rhythm disturbance, they may not be the right candidate for use of hydroxychloroquine, whether as prevention or for treatment. But otherwise, it is considered to be a quite safe molecule, hydroxychloroquine, because it has been used in many rheumatoid arthritis patients, okay, for many years, and there is not too many serious adverse events have been reported truly. Then there was also another molecule, that is ivermectin, which is basically a broad spectrum antiparasitic agent, and that has also been popular for prevention of this disease and also sometimes treatment of this disease. Uh, these are some of the preventive measures: immunoprophylaxis and chemoprophylaxis. So far as immunoprophylaxis or vaccines are concerned, specific vaccine, when you talk of, we don't have really too many uh, any vaccine that has actually come, okay, for general use right now, although some of the vaccines in some parts of the world, they are claiming that it has already been it can be used for general purpose, but uh, enough evidence are not available in the public domain, okay. Coming to the treatment, okay, they broadly speaking, we can classify the available treatments into these broad heads. One is antiviral, okay. Second is about supportive therapy, where you can again divide into, if we consider COVID, actually, if we try to understand the pathogenesis of the disease, then it is actually, although it is a viral disease, but it is truly speaking, the complication of the viral disease, this viral disease, is actually proving fatal, okay. And the kind of complications are actually because of a hyperimmune, hypercoagulable, hyperinflammatory state, okay. So there are certain degree of some degree of pro-inflammatory mediators that are released, okay, in you can say uh, uh, a, a, a distorted response, okay, immune response, okay, heightened immune response, which uh, actually is not doing much good to the host, rather is proving itself to be fatal, okay. And because of this hyperimmune response, okay, particularly because of the T cell mechanism, T cell arm of the immunity, that is being disturbed in a way that it is causing release of certain pro-inflammatory mediators, and these pro-inflammatory cytokines are released at a huge this thing, what akin to a, so to say, a storm like situation, and these are actually responsible for causing inflammation with again a particular preference for the lung tissue, and thereby it is causing fibrosis, okay, inflammation and fibrosis in the lung alveolar bed, as a result of which the perfusion capacity, okay, in the lung is reduced, okay. So the oxygen saturation drops, and there is breathing distress, and this is the reason. Apart from that, there is also the fibrinogen system, or the coagulation system, is also affected, as a result of which there is also a state of hypercoagulability. So because of these two reasons, one is inflammation, hyperinflammation, and the other is hypercoagulation. Because of this understanding, we started using glucocorticoids for its anti-inflammatory property, and also low molecular weight heparin for its anticoagulation property. So these are, again, of course, these two different types of therapeutic measures are actually benefiting as a supportive therapy. The third category is that of immunomodulatory agents, because there is a immune stimulation, hyperimmune state. So you can think of, and we have spoken already about some of the pro-inflammatory cytokine. Like one of the important pro-inflammatory cytokine is this IL-6 or interleukin 6. So people try to also try the anti interleukin 6 monoclonal antibody, okay, and expecting that that will do the wonder. and at least there has been some success with some anti IL-6 molecule, okay, like tocilizumab, okay, uh, uh, and so uh, people have also tried with some success with these molecules. Besides, there is also another kind of therapy that is called convalescent plasma transfusion therapy, and there we expect somebody who has already suffered COVID-19 and recovered. So we expect that they will have in their system the neutralizing antibody level raised to a certain critical value, and after say 4 weeks of their uh, recovery, okay, we can if we can measure the antibody level, and if it reaches a critical value, theoretically it is possible to extract those plasma along with that antibody and transfuse it to the person who is suffering from COVID, expecting these antibodies will actually, of course, after the necessary matching, cross matching, etc., HLA typing, etc. And then when you do this, then these antibodies, neutralizing antibodies, will uh, actually prevent the antigens, okay, antigen antibody reaction. They will neutralize the antigen, viral antigen. So that is the concept, that is the idea. So people have started using convalescent plasma, okay. Besides, of course, we have spoken about ivermectin, although initially there was some enthusiasm with ivermectin because of some in vitro study results that it has antiviral property, but then people understood the dose or the strength that is used in the in vitro culture, when you translate that into clinical dose, it becomes too huge to be used in clinical setting. So if at all ivermectin is producing some benefit, perhaps it is not because of its antiviral property, rather it is because of its immunomodulatory property, because it has been seen it ivermectin also, okay, uh, helps in particularly the cellular arm of the immunity, okay, and thereby the T cell activity is modulated so that it may be effective. So, but then we are still in the phase of learning phase so far as ivermectin is concerned, and lot of oxygen therapy remains the mainstay of treatment, and it is quite obvious, quite understandable that because there is a pathologic changes in the lung, okay, so the lung bed or the alveolar bed loses, at least partially loses its ability to engage itself into gas exchange. So although we are inhaling oxygen, that oxygen cannot be actually exchanged at the lung alveolar bed. So what we try to do, we try to increase the partial pressure of oxygen. As we know, at room air that we breathe, okay, the oxygen concentration is to the tune of 16% to 20%. But in COVID, that may not be enough. So that's why instead of room air, we try to supplement supplemental oxygen therapy. We give it by nasal catheter, okay, and then even with the nasal catheter, when you take a nasal catheter, you are actually taking oxygen, additional oxygen, but then it is mixed with the atmospheric air. But then that may not be enough. So you need to increase the pressure of the oxygen by increasing the partial pressure of oxygen, availability of more supplemental oxygen, and that is possible when you are giving it, pushing it by positive pressure ventilation. So that is how gradually you increase the availability of oxygen at the alveolar bed. And but then uh, this is to be also monitored, that even if I am raising the oxygen pressure, whether the oxygen saturation is being maintained, and that is done very otherwise easily these days, okay, by use of pulse oximeter, okay. And there actually it is said the critical value of pulse oximeter that must be maintained is 94%. Anything more than 94% is acceptable. The moment it tends to dip below 94, then possibly it is our oxygen saturation is getting compromised, and in order to get it back to the acceptable level, you have to give more of, you have to increase the pressure of oxygen artificially. So that's how it works. And then at the extreme phase, stage, one can a very severe phase, when maximum oxygen pressure, that is to the tune of say 15 liters, okay, per hour, if it is not sufficient, then you have to again think of, okay, at that level you have to again think of some kind of, you can say, artificial lung system, that is ECMO, okay, extracorporeal membrane oxygenator, ECMO therapy. So this is how you can modulate actually different types of oxygen supplemental oxygen therapy. Okay, so can you go to the next slide, please? Would the slide be available?
Yes, sir. There is some problem in the slide sharing. So they are just joining again and showing the slide. You please carry on, sir.
Okay. So today we are going to actually discuss these different drugs. Uh, I'll go now. I'll go a little faster in order to accommodate for the time. Uh, the next slide actually is a cartoon. It's a picture diagram. So without the diagram being projected, there is no point in trying to describe that. I pass on to the next slide. Okay. Um, the principle of drug therapy is actually based on how with the progression of the disease and how the virus behaves after it enters our system. Okay. Uh, is the slide back? No. Okay. So what happens that you might have heard, this is the fifth day or the 10th day. When you listen to some discussion about COVID, people talk in terms of days. Okay, so what is this day? How do you count when you say fifth day? What does it mean? If this is the fifth day, what was the first day? From which day do you count the fifth day or the ninth day or the 15th day? So it is actually, it should be from the day of exposure, but we do not know when the exposure happens. We only suspect that there it might be COVID because we know the symptoms more or less. Okay, although the symptoms are not very unique, these symptoms are overlapping with many other viral disease or even some bacterial disease. Okay, pulmonary bacterial disease. Okay, but then uh, the symptoms like fever, symptoms like dry cough, okay, uh, symptoms like body ache, malaise, all right. So when or the loss of smell or loss of taste, okay, so all these, they are very much overlapping, they are not very unique for COVID. But then during this period of COVID pandemic, whenever anybody is complaining of these symptoms, we should suspect, we should rule out COVID. And for ruling out, there are also mechanisms how you can rule out, or rather how you can rule in, that is how you can diagnose, okay, COVID. There are also now consensus on that. We'll discuss that. We all know the mainstay of diagnosis.
Sir, sorry to
It
interrupt,
has
sir.
come.
The slides are back,
Okay.
so you can use the PPT. Yeah, yeah, sir.
Okay. Now this slide actually, I'll skip this slide rather. This slide is actually the mechanism of the different drugs, a schematic diagram. So this is the cell, okay, epithelial cell or the lung epithelial cell and the virus. Okay, this is how it enters. We have discussed the virus, okay, how it interacts with the ACE2 receptor on the cell, and thereby how the virus enters into the cell, and then it actually replicates the RNA, replicates the RNA, is how it replicates, and finally it comes out of the cell. And in the different stage of its journey, it enters into the cell, and then using the cellular material, genetic material, and then finally replicating and finally going out of the cell. In this journey, at different level of this journey, different drugs, they can actually try to prevent this journey, stop this journey by inhibiting or by blocking, etc. I'm not going into detail of this, okay, each individual drug, but this is broadly speaking how we have tried to understand the drugs that possibly are helping, how they might be helping. I'll be skipping this slide. Go to the next. Please change the slide. Go to the next slide. Yes, this slide is very important. I was talking of the progression of the disease. Go back to the previous slide. Please go back to the previous slide. Back. Yeah, this one. Stay there.
Yes, it is. It is.
So here you see that x-axis is duration over days, and the y-axis is the morbidity type or the disease severity. Okay. Now I was talking about the days. So the day should ideally be counted from the day of exposure, but because during the exposure there is no symptom, okay, asymptomatic phase or pre-symptomatic phase, we do not know what is day one. So in reality we count the days as the day of the first symptom. Okay, so if today the symptom has started, fever or dry cough, that will be day one, and then uh, from that day it is believed, and there are evidences also, that it is around the day 5 when the viral replication would be high enough. Okay, the viral load would be sufficient in order to detect it by the available diagnostic test, antigen test. Viral antigen is detected. Okay, if anybody tries to, say for instance, it is this is the fifth day. If anybody is trying to test on, say, day 1 or day 2 or day 3, the viral replication has not been enough in order to in order to get it detected by the antigen test, RT-PCR antigen test. Okay, real time polymerase chain reaction test. Okay, so uh, that will be a diagnostic dilemma. So you go, you test yourself and you find it is negative. That doesn't mean it is actually a false negative, because the virus is already there and virus is replicating, because you have tested it prior to the day when it can be detectable, so it is showing negative. So if we want to test, we should try to test it around maybe either fourth or fifth day or sixth day. That is the right time. But unfortunately, by the time you are detectable in the test, the virus has started its havoc, started damaging. Okay, and what is the first organ it damages? It damages the lung. So although it is the fifth day when we are diagnosing, again it is the fifth day, okay, when you find it has already caused sufficient cytokine liberation, and those cytokines are causing, okay, the fibrosis, inflammation and fibrosis, hyperinflammation and fibrosis in the lung bed in the fifth day itself. So more or less in parallel, on the same day, fifth day, you are getting this the virus detected, and on the fifth day you go for a high resolution, okay, computerized tomography, HRCT of lung. You will find it is likely in most of the situation you will find that there is bilateral ground glass opacity, which is again pathognomonic of COVID-19. So what does that mean? That by the time it is fifth day, there is a possibility that it is already causing damage. Not necessarily each and every person you will get a positive uh, imaging, okay, for COVID, but then there will be most of the patients, they can actually fight with their immune system can fight with the virus. Okay, so they in those cases there will not be enough cytokines that will be liberated. If the cytokine storm, it doesn't happen, cytokine release syndrome doesn't happen. Okay, and what I am stressing is cytokine release syndrome can happen as early as the fifth day, and that is the reason there is argument, okay, that if you want to have good benefit, then start the anti-cytokine therapy early enough, start the anti-inflammatory therapy, that is with steroid, early enough, that is around that fourth and fifth day, sixth day. Don't wait until the severity of the disease becomes more severe. So we need to also understand what is the day when the viral replication more or less stops. The viral replication more or less stops on the ninth day or the 10th day. If it is so, then if at all you want to, okay, prevent the replication of the virus, you should do it prior to ninth day, not wait until the disease is severe and try to treat the patient on the 14th day with antiviral drug like remdesivir or favipiravir. So that is not a good strategy. So the antiviral drug you have to give prior to ninth day. The remdesivir, how long it is given? Okay, whatever evidence we have, it is a 5-day treatment is enough. People have also done 10-day therapy, but and also have compared head to head 5-day versus 10-day, and people have seen that 10-day is not offering any extra benefit, additional benefit. There might be some safety concerns with 10-day, so 5-day is enough. But if you are going to use remdesivir, okay, as an antiviral agent, it's an antiviral agent, then you have to use it before the ninth day, because it is to be given for 5 days, and beyond ninth day it is not going to really help. Then it has to be started from fourth day. So 4, 5, 6, 7, 8, or 5, 6, 7, 8, 9. So fourth or fifth day you have to start the antiviral drug. Again, fourth or fifth day you have to start the dexamethasone or steroid. Again, fourth or fifth day you have to start the low molecular weight heparin. Of course, low molecular weight heparin, there is also a understanding based on evidence. There is a scope for you can say prophylaxis with steroids or prophylaxis with anticoagulants. Okay, that means you start early, and then if you see that there is a possibility of more severity, then you give a therapeutic dose. So there might be difference in the prophylactic dose and therapeutic dose, but we need to understand the logic behind early initiation, early institution of anti-inflammatory dexamethasone, okay, immunomodulatory tocilizumab, or antiviral, okay, remdesivir, even ivermectin, if you think of antiviral, or the hydroxychloroquine. So all the drugs you can think of, whatever drug we have discussed, all the drugs you can think of, all these are actually, in order to get best results, we have to start it early enough. Now the question is whether the severity grade of the disease will also determine which drug we should start and when we should start it. It is true that the initial phase, it is in the initial 5-6 days, that will actually determine whether the patient is going to more severe, transitioning to the more severe phase, or it is getting limited by the participation of my own immune system to be otherwise aborted in the milder phase. Okay, so most of the patients in general are going to get cured, okay, within the mild phase, is not transitioning even to the moderate phase. Okay, out of every 100 patients of COVID-19, all right, so more than 80, that is 80%, okay, will otherwise be in the milder phase, mild COVID infection. Okay, then maybe another, or maybe 75, there might be another 10 which will be transitioning to moderate phase, but with the treatment they will also recover. There will be some, okay, around say 15 or so, who will progress to the severe phase. Okay, so the mild phase, they might not require even hospitalization. Mild patients, they can be treated at with home care. But the moderate and the severe patients, again, how do you know who is moderate or who is severe? Again, it is the oxygen saturation that will tell you that it is moderate or severe. It is uh, the the presence of the different inflammatory mediators or the markers of inflammation, whether it is CRP or whether it is ferritin, okay, whether it is LDH, okay, lactic dehydrogenase, etc., whether it is even ESR, whether it is lymphopenia, okay, lymphocyte, low lymphocyte count. Okay, so they will, or rather, more correctly, it is the neutrophil lymphocyte ratio. Okay, so all these parameters, they will actually then D-dimer, okay, which is again a marker of your distorted or the coagulation balance, okay, clotting balance. So these will actually decide whether there is the tendency of this patient to transition to the next phase of more serious severity grade wise, it is going to the more severe phase. And then accordingly, and also the other thing that will determine is the oxygen saturation, or more precisely, it is the ratio of FiO2, okay, so and the SpO2, okay, or PaO2 rather. So that is that ratio will also determine whether it is below 100, or maybe 100 to 200, or more than 200, something like that. So that will also actually determine whether it is going to more serious condition or not. So accordingly, one needs to decide how the treatment is to be planned. And then again, one needs to be extra cautious again about the background comorbidities. They will also determine the success of any treatment. So if simultaneously the patient has diabetes, okay, and this disease itself, okay, will also disturb the different metabolism, like carbohydrate metabolism, the fat metabolism. They are also disturbed and distorted by even if I am not okay. So if you remember that particular slide, the two domes, okay, uh, that is actually representing the virus mediated morbidity. And in the initial phase, it is the virus mediated morbidity, but then the virus mediated morbidity does not continue beyond the 10th day. And then the exaggerated immune activation mediated morbidity, that starts from say day 4 or 5, and that will peak itself on say day 12 or 13, okay, or 14,
Sir, sorry to interrupt.
and
We
then
have to finish by
around
three
say
to four minutes. Then we have to
if
take
everything
some questions.
in finished by how many minutes?
3 to 4 minutes, sir.
Finished. Okay, okay. All right. So here you see, this is another slide that actually shows this more categorically, that this phase is the viral replication phase. So this is the say day 0, or the first starting symptom, and then gradually, initially it is that early infection phase, or the viral response phase, viral replication phase. And then this is the stage 2, or the pulmonary phase, when it is causing the damage to the lung bed. And then the host inflammatory response also starts. Actually, it is the host inflammatory response that is causing this pulmonary phase also. And the last phase is the hyperinflammation phase. So accordingly, the treatment is to be planned, strategy is to be planned this way. Okay, we have stated the major treatment approaches are there are antiviral drugs, anti-inflammatory drugs, like steroids, dexamethasone. Then we have this the immunomodulatory drugs, and then we have these drugs which will otherwise control the hypercoagulability. Okay, so that is low molecular weight heparin. So these are the different types of treatment strategies, and also we have these uh, the older drugs which are also used in the treatment. So that's how we can try to plan our treatment. And as we know that milder varieties, they can receive the treatment staying at home, and then but the moderately severe and the severe diseases, and also those who are at higher risk, they should get admitted. And only institutional therapy with oxygen therapy and other supportive therapy can be made possible only in institutional care. I think we can stop it here. It's a huge subject, and we didn't go into detail of each individual drugs, but I can try to take some questions. and maybe while answering questions we can use certain drugs related to specific drugs. Okay, so I'll
Thank you, sir.
request the slide presentation also to be in place. So while answering question, I can try to use certain slides also.
Okay, thank you very much, sir, for this discussion and presentation. So, first question, that we all know that pregnancy is one condition where we can say they are pregnant ladies are clinical trial orphan. So here is one question: will there be any impact on pregnant women due to any COVID drugs? So what anti-COVID drugs we can use safely? Uh, what is your opinion, sir?
So you cannot just say absolute safety. When you talk of treatment of pregnancy, when it is complicated with serious condition, different serious condition, you have to think of the relative risk benefit ratio. And when you talk of relative risk benefit ratio, it is the, again you have to do prioritize, that it is the maternal well-being that is given priority over the fetal well-being. Of that doesn't mean that we should not think of securing the fetus, developing fetus, but to the extent possible, if possible, we have to retain the pregnancy. But then, if we have to sacrifice, we will be sacrificing the pregnancy, but we will try to save the mother. So that is the general approach. Now, the different drugs, whatever we have discussed, again, some of the new drugs we do not have enough experience about their safety in COVID in pregnancy, whether it is remdesivir or whether it is tocilizumab, etc. But then, so far as the older drugs are concerned, like steroids, yes, steroids can be used in pregnant women who is suffering from COVID. But then again, when you think of the low molecular weight heparin, yes, we can use low molecular weight heparin. Regarding ivermectin, there is another question about ivermectin. I think ivermectin it is better not to use in pregnancy. Uh, but otherwise, so far as use of drugs in COVID is concerned, so far as mild COVID is concerned, it is better to limit the use of uh, drugs which do not have a very clear efficacy or evidence based, not to use it in pregnancy. But if there is milder infection, it should be properly monitored and regularly put under surveillance. And only when there is a tendency for the different parameters or the markers they are otherwise available, then only you can think of starting with corticosteroid, that is dexamethasone, or you can think of starting with low molecular weight heparin. Okay, but otherwise I would not recommend in favor of hydroxychloroquine or for that matter the ivermectin, etc. Neither is doxycycline, okay, for that matter.
Okay, thank you, sir. There is some studies are ongoing in USA on remdesivir in pregnant women, and
Right.
there are some case series also on remdesivir, and they're found to be safe. But again, we have to be cautious regarding its use in pregnancy. So next question is: recently it's found that plasma transfusion, that plasma therapy is not effective. So why it's so? So what is your
Yeah,
opinion on that?
yeah. Theoretically, plasma therapy or the convalescent plasma, rather more correctly, convalescent plasma therapy, people who have recovered from COVID, and that again it is said that if somebody has recovered from milder variety of COVID, so they are not the right candidate for to act as a donor of plasma. Okay, so somebody who was hospitalized means they are not really mild, higher grade than mild, moderate or moderate to severe or severe cases, and has recovered. Okay, so it is expected they will have sufficient antibody titer. So if there are evidences to demonstrate that a severe COVID patient have a greater chance of having sufficient antibody level rather than a milder COVID patient. Okay, a patient with mild symptoms or no symptoms. Okay, so that's why that somebody who was hospitalized, who has otherwise survived an attack of COVID, and then on the 28th day, not before 28th day, after the fourth week, okay, they can be tested that whether they have enough antibody, and antibody is neutralizing antibody is detectable. Okay, that is, they will be subjected to serology, and IgG is detectable. But again, there is a catch there. Only detectable is not enough. Although for routine practice we are using only detectable, but then why we might have we might know that in India the ICMR had conducted a multi-center study. Okay, quite a good number of patients. Okay, they received this convalescent plasma therapy. There were almost more than 40 centers. Okay, multi-center study they conducted, and they could not find any difference between plasma therapy and patients receiving plasma therapy versus patient not receiving. One of the possible reason is the plasma therapy, when it is given, the donor possibly did not have sufficient titer of the antibody. Okay, because titer estimation is not possible in every center, so that was not possible. However, in this study at least, they had also later on sent the material, okay, to the central nodal laboratory, and then uh, the titer was also estimated. Although the treatment has already been given, but that data was used for analyzing, and it is found even those who have a high titer, even there also it is found it is unable to really give protection to the patient. Okay, so in India, our experience, and another separately conducted study in All University of Medical Sciences, Delhi, they also found it is not effective. However, in other parts of the world, people are showing it is effective. So the evidences are a little conflicting about the this is the role of plasma therapy. Okay, although theoretically it is possible, but in reality we are not getting a very good response with plasma therapy.
Okay, thank you, sir. And we will take the last question, that can doxycycline or azithromycin used as prophylaxis?
Yeah, it is true that both doxycycline and azithromycin has been used. Initially, there was some reservation that this can lead to, although they do not have very direct evidence that they can help. Okay, but how they came up? Because of some of the preliminary finding and some other viral diseases. Okay, it is found in vitro studies. It is found that both doxycycline and azithromycin, they have some antiviral property also besides the antibacterial property. Okay, that's how it's used because of this theoretical basis, and also in vitro evidences. People have people had started this doxycycline and azithromycin, okay, not just for prophylaxis but also for treatment. But gradually we are getting more and more information. Some of them are promising, and even as prophylaxis also people have started using doxycycline and azithromycin. But as on today, the weight of evidence is not enough really to put this into any kind of guideline, at least for prophylaxis. But for treatment, if not as a sole agent, as a part of the combination therapy, other antiviral agents or other immunomodulatory agent, doxycycline and azithromycin, both are being used.
Thank you, sir. So mostly we can use doxycycline or azithromycin in the treatment of COVID-19 patients.
Yes,
Specifically, apart from the antiviral effect of this type of antibiotic, most the immunomodulatory effect,
also
specifically against the that is the inflammatory cytokines, they have some robust evidences.
absolutely.
So,
Yes,
so thank you very much, sir, for this great presentation. And so I just want to thank American Association of Yoga and Meditation also for this, for giving us this opportunity. And there is one definition of yoga in Gita that I just want to finish with that two slokas. That is number one, the karmannevadikaraste ma phaleshu kadachana ma karma phale turbhu ma te shangasta karmani. Next is that Yogastha Kuru Karmani Sangang Takta Dhananjaya Midhvar Dhamyo Savo Huktya Samatyang Yoga Udvate. That means you have the right to perform prescribed action, but you are not entitled to the fruits of the action. Do not make the rewards of action your motive, and do not develop any attachment of for avoiding that action. Apart from that, if you just want to define yoga, that is situated in yoga, perform your actions, giving up all attachments, Dhananjaya. Remain equal in success and failure. For such equanimity is that meant by yoga. So now in this time, we doctors are doing most probably this yoga practices, and we hopefully within few months will have our goal. So thank you all for giving us this opportunity.
So before I conclude, I think there is also, apart from the spiritual part, the yoga practices and meditation might also have an interface with the objective evidences of helping in particularly in different kinds of respiratory disorders, including COVID. And there are evidences coming up. If you do certain kind of respiratory exercises, okay, you can probably fight the disease better. Evidences are coming up. So time will not permit to
Yes, sir. We also conducted some studies in our institution under your guidance regarding the Om chanting on COPD. So we get some benefit as Om chanting reduces the anxiety score. So that gives some benefit to our COPD patients compared to the non-Om chanting group. So there are some definite evidences with yoga and meditation in treating respiratory diseases, and hopefully we can conduct more studies on this perspective also, and we will get newer evidences for helping the mankind. So thank you all for giving us the opportunity. So there is some disturbance in, sir, can you hear us now? You can hear us, sir?
Yeah, I can hear you.
Okay, sir. Please, sir,
Yeah, we can
conclude.
hear you.
Please conclude, sir.
Yeah, I have nothing more to say. Thank you very much, all the organizers, for giving this opportunity. It was a great opportunity. I hope that we have been able to make this session useful to the listeners. Thank you again. And thank you,
Thank
Dr.
you.
Shambho, for acting as the
Thank you.
moderator.
Thank you. Thank you, sir.